Hello, I'm Dr. Daniel Griffin,
And I'm Dixon DePommier.
and today we will be discussing hypertension,
Wow.
elevated blood pressure. You know, I think it's more than that, right? We think of it as elevated blood pressure, but it's a whole syndrome, and the elevated blood pressure is really what we're recognizing, what we're tracking, but it's really a whole inflammatory process that puts us at risk for cardiovascular disease, right? So heart attacks and strokes, kidney complications, so kidney failure, might end up on dialysis.
Eye problems.
You might end up with blindness from, so there's a lot of complications that can come from just the blood pressure being too high.
Exactly.
Now, we're going to use your age here. Now, Dixon, when you were a young man,
I'm
maybe
a young man, please.
yes, now that you're still a young man, there used to be an idea that there was the systolic, which is the upper number, and the diastolic, which is the lower number.
Yes.
And physicians used to be only concerned about the lower number being elevated.
So they did.
And they would say that the top number, 100 plus your age, is acceptable. Right?
For me, there's no limit to that number.
So it would keep going up. But along came evidence-based medicine, where
darn.
someone decided, let's see how true that is.
Yeah.
And this is where they began to realize that both the diastolic and the systolic number matter. Elevations in either predict an increased risk of strokes, heart attacks, all the other problems. And so it became the issue that you want to worry about both.
You have to worry about everything.
You do now.
Nowadays you
have to worry about everything, and your blood pressure goes up.
That's exactly right.
So as far as clinical disease, a lot of blood pressure is diagnosed through screening. Someone comes to medical attention for some other reason.
Yes,
Their vital signs are checked.
indeed.
And the vital signs might be your respiratory rate, your heart rate, your temperature, and your blood pressure.
So probably you're going to ask me a question about my blood pressure.
I actually, I don't, do you have blood pressure challenges?
My wife used to work for a hospital that had a health fair every year. It was associated with a closure of a street, and they had a street fair associated with that. And they had a booth along that street. It was next to the hospital. And what they would do for you, free of charge, they would measure your blood pressure.
Okay.
They would sit you down on a chair, and you'd put out your arm, and they would put the cuff around, and they'd pump you up, and then they would let it go down, and they would time it. And if you had a blood pressure that exceeded a certain number, and we won't go there yet, they said, you ought to go right in over here and get checked. You've got high blood pressure.
Okay.
So
Was there a financial connection there?
there might have been a slight
Okay.
financial
All right.
connection. So my wife, not knowing any of this, was manning this booth. I stopped by. I had my blood pressure read. It was off the charts, basically. And someone came over and said, this person needs to be admitted right now. Of course, I didn't do that. But the curriculum director for our medical school at Columbia happened to be a cardiologist.
Mm-hmm.
His name is Dr. Ronald Drusen.
Okay.
So the next day, I went to Ronald Drusen and I said, what should I do? He said, what time of the day was it? I said, it was in the middle of the day. He says, what were you doing before they measured your blood pressure? I said, I was walking down the street. He says, you mean he says, yeah. He says, here's what I want you to do. Buy a blood pressure machine. Measure it every morning when you wake up. Measure it every evening before you go to bed. Do that for 1 month without missing a single day. Come back and see me. I said, sure, I'll do that. Because this was when I was much younger, by the way.
Yes.
And I said, I don't want to die from this. I want to be healthy. So I did exactly what he said. And we both looked at the registered numbers that we got from the blood pressure measuring machine, recorded everything, and every day I did this for 1 month. And I brought the data with me to Ron, and I put it on his desk, I left it there, and I went home. The next day he calls me up. Of course I thought, now I'm going to get the bad news, right? He says, you're perfectly normal. I said, really? I said, well, then what caused this high number during the middle of the day? He says, well, there are lots of things that affect blood pressure in a normal way. that have nothing to do with whether you've got hypertension or not.
Mm-hmm.
So you didn't define what hypertension is.
So that's true.
Would you please do that for me? Because I'm dying to know what your definition is.
Yeah, so we talked about the fact that a lot of people are diagnosed because they're screened. Someone took their blood pressure.
They did.
And it was above a certain threshold.
It was.
And we're going to talk about what those thresholds might be because they're going to vary.
They will vary.
They will vary. Other people come in because they have symptoms. And what symptoms might be? The symptoms might be they come in with chest pain.
Yes.
They might have headache.
That's right.
They might have blurry vision.
Exactly.
They might have shortness of breath, trouble breathing. So what is normal blood pressure? So this almost reminds me of our fever thing, where we talk about lots of measurements.
That's right.
And blood pressure can be measured when a person is sitting there relaxed. It can be measured in the morning. It can be measured in the evening.
Right.
It can be measured with a small cuff or a large, appropriately sized cuff.
Which I didn't have, of course.
And so and when someone exercises, blood pressure goes up, and that is an appropriate physiological response. So when we're talking about blood pressure, when we're talking about the numbers, we want the person sitting. We want the arm up at heart level. So you really want them sitting at a proper table, not a low table where the arm is hanging down.
That's right.
So they want to be sitting comfortably, relaxed, without their legs crossed. You want a cuff that's the appropriate size, so a larger cuff, not something that is less than half of the diameter of the distance from here to here in the upper arm. You want to give them a few moments to relax, because if someone is actively exercising, walking down the street, and you say, take a seat and immediately do the blood pressure, you're not getting the blood pressure number that's going to be diagnostic. You're getting an elevated blood pressure that is associated, which is customary, which is a normal response to exercise.
Do you wear a white coat when you administer this test?
I always wear fancy suits, but we'll talk about that too.
Good.
There are a couple things. You want it to be in a comfortable, relaxed context. There is something called white coat hypertension. I'm going to talk a little bit about that. Nobody wants to have hypertension.
Nobody.
Everyone denies having hypertension. So there is a syndrome that has been described where people say, oh, my blood pressure is just high because your coat is white. And it's called white coat hypertension.
It's true.
And so people often, they take their blood pressure at home and they might lay there, they might meditate, they might look off into the sky.
That's right.
And because they're very, I should say, desperate to get good numbers. You want to pass this test.
You do.
One of the things I point out to people is if sitting down with me, and I am a very relaxed, friendly man.
You are.
If sitting down with me, having your blood pressure taken elevates it, there's probably a lot of other things in life that are elevating your blood pressure.
Right.
What if you ever drove your vehicle or rode your horse or walked down a busy street or interacted with other human beings? And so one of the things that they'll actually do in resource-rich areas is they'll have a person wear a blood pressure cuff which takes their blood pressure randomly through the day.
That's a great idea.
So this way, when you and your spouse are having an issue, when your child does something they shouldn't do, you start seeing these elevations through the day. Because what really is the most predictive of blood pressure and risk is your average blood pressure throughout the day.
Got it.
And so we crudely do spot checks when someone is relaxed and sitting and in a semi-meditative state. And we use certain numbers, and those numbers might be, let's say, about 120 over 80. But again, that might not be ideal blood pressure for a large man like yourself. And it might be an elevated blood pressure for a small woman.
Right.
And it might also not be accurate for a child.
Or my wife, for instance, if you ask me what her blood pressure is, she was clinically dead 3 times according to the clinicians, and of course it was normal for her.
Yeah. So
she has very low blood pressure normally.
Yeah. So that's one of the things when people say, well, what is normal blood pressure? And the answer really is, it depends.
Right.
It depends upon the individual's body habitus.
Of course.
There's some impact, we'll say, with the time of the day.
Yep.
And so what you want to look at is a rough estimate, and the WHO actually uses particular criteria.
Yeah, they have no choice. I mean, they have to lose something normal to give guidelines, but it's generalized, right?
And some of the issues, and I think this will help with why do we care about it, what numbers are we dealing with, is that for every 10-point elevation in blood pressure, you're going to double your risk of a stroke. Right? So that's one of the things to be thinking about. Exactly. So in a lot of areas, like the United States, we'll tolerate up to 140. If your blood pressure, whatever your blood pressure is, if you're comfortable and not lightheaded, it's not low.
Correct.
It's not. You're not hypotensive.
That's the definition.
For
that's
you.
The one I want to
hear.
Yeah,
normal blood pressure is a blood
true.
pressure at which you're comfortable and flexible. Now, hypertension, high blood pressure,
that's different.
Once you start to get above 140 is when we start to see a significant increase, that's systolic. Once we start to get above 90 on the lower number, that's when we start to see significant increases in your risk, particularly of strokes. Heart disease also, kidney disease, eye issues, but the biggest association is with stroke risk.
Indeed.
And so a lot of different contexts will use different cutoffs for treatment, and they use different contexts for goal of what you're trying to push the blood pressure down to. Right. And if you think about the different populations, let's say you're in an area where the life expectancy is in the 50s. Oof. Are you going to spend a lot of resources on tight blood pressure control?
Not really. No.
A lot of clinics won't even check blood pressure because of that. Or if they are checking blood pressure, they're checking it as a vital sign, not as something they might really want to treat unless the person also has symptomatic hypertension.
Got it.
I was giving a lecture in Scotland, in Glasgow.
Yes.
And there was an individual in the audience, and I presented a case of hypertension. And his immediate response was, "You must use this drug." I pointed out that drug would be 50% of our drug budget for the entire month. But there was really a rigidity to, this is the blood pressure, this is evidence-based. But I'm going to suggest, at the risk of being controversial, that you really need to look at your resources and decide how much is hypertension a problem in my population.
Right.
How many resources do I want to look at spending on this? Because we would routinely run out of our malaria medicines, with a week to go in the month, and we would run out even sooner if we were buying the Cadillac, the fancy, expensive hypertension medicines to treat what might be an appropriate paradigm in the United States, but doesn't make sense in a different context.
So my understanding also is that once you start hypertension therapy, you have to stay with it. Is that true?
It's usually true. Yeah,
so that even adds more of a longitudinal expense that you're not prepared for.
Yeah, this is much like the way we approach diabetes, where this is now a chronic disease. The paradigm has changed. Right. We're not going to cure hypertension. And we can manage it. We have ways of managing but not curing.
Exactly.
And so if you do commit, this first month you start with one individual being treated for hypertension. Next month it's 2.
Got it.
Next, maybe you have 10 after that. As that starts to increase, you're going to start putting more resources towards that. And where do those resources come from? They often come away from somewhere else.
Exactly.
So I don't use a lot of numbers. We don't give a lot of numbers in our book about what the thresholds should be, because the thresholds really, I think, need to be individualized for your context, for your practice setting.
Can you mention some regions of the world where hypertension is a major problem in health?
I would be hard pressed to find an area where it was not.
Really?
Stroke and heart disease, like diabetes, are now growing problems in much of the world. Wow. Competing with other diseases. But many populations in the world are very salt sensitive. So one of your inexpensive ways of managing hypertension in sub-Saharan Africa really might be salt restriction. Not going to do a lot in a Caucasian population that is less salt sensitive. Might be helpful in certain Asian contexts. And then we will talk a little bit about management. Okay. Let's say we are going to use our medications. The WHO and a lot of other groups say that if there are compelling indications, that will guide you towards one medication. But in general, they say use what works. But if someone has heart disease, if they have kidney disease, if they have heart failure, if they have a certain rhythm disturbance, you may want to pick one class of medication over another. But without those, you're going to pick a medication that works. And that may be different based upon the genetic context. So if you're in an area of the world where, let's say, there's limited access to fluid, you may not be wanting to use one of our diuretics, right? Where if you're in a salt-sensitive population, your diuretics, such as hydrochlorothiazide or bendroflumethiazide, might be your first-line medications. In other areas where there's no laboratory monitoring and your amount of fluid intake is limited, you might use a calcium channel blocker, such as amlodipine. So this hypertension may seem pretty simple and the bread and butter of a lot of clinicians that are going to go out to practice in these areas. But when you're going to go to an area, you want to think of the larger picture. You want to think of all these factors: threshold for diagnosis, threshold for treatment, and what might be an appropriate medicine in a different context.
See, you just brushed on age group dependency. Did you just reiterate that just for the life table?
No, I think that's important too. If you have an 80-year-old individual in a community where their life expectancy is very short and they've been living with blood pressure at an elevated level for a long period of time, are you going to jump in and put them on medication? You got to make a decision. Does that make sense?
Yeah, but early onset, I mean, at what age group do you see a change in the curve?
It really goes along with age. So the older an individual.
It's 1-to-1?
Well, I think we can remember that lesson we used to say, 100 plus your age.
Oh, I see.
And your blood pressure, your particularly systolic, and the diastolic also. As we get older, there's usually an increase in the number. And you could say that's a normal part of aging, but you could also say having a stroke is a normal part of aging. And so what our goal when we treat hypertension is to change the normal. I want to make it to 100 without a stroke.
Right.
That's not normal.
No, it isn't. No, that's definitely not.
All right. Well, I hope everyone enjoyed our discussion on hypertension. And we look forward to talking to you again.
Yeah, we'll see you again soon.